So we have Dr. Hemant Ramchandra who will be presenting on presumed CAPECITABINE induced optic neuropathy and maculopathy, a case report.
Good morning, everybody. Today I'll be presenting a case of presumed capacitabine-induced optic neuropathy with maculopathy. The background of the study: the incidence of chemotherapy-associated ocular toxicity is on the rise with the advent of newer chemotherapeutic agents. So actually the use of multiple drugs along with the radiotherapy sometimes makes it very difficult to interpret this, the toxicity of these drugs. So actually the quality of life in these patients will be further compromised due to the poor vision, making the situation a bit more worse. So we hereby report such case of presumed chemotherapy-induced optic neuropathy and maculopathy in a patient who was on capacitabine for colon cancer. So and then coming to the case history, a 32-year-old female who presented with sudden onset painless blurring of vision in the left eye for the past 15 days, and then there was no history of any flashes of floaters, and there was no history of any limb weakness or fever, and there was no history of any transient obscuration of vision, and then she was a known case of carcinoma colon, and then who was on actually capacitabine. She had already completed 3 cycles by now. So actually no other known systemic comorbidities. Then coming to the examination, the general physical examination revealed significant pallor, and then coming to the examination of the right eye, the vision was 6/6, and then the pupils were actually 3 mm. The direct reflex was brisk, whereas the consensual reflex was sluggish. So and then coming to the examination of the left eye, so actually the vision was actually 6/9, and then the pupils revealed 4 mm. Grade 1 relative afferent pupillary defect was noted, and then the IOP was within normal limits. So and then coming to the posterior segment, the right eye fundus was within normal limits, whereas the left eye, the disc was hyperemic, and then there was infranasal and infratemporal disc margins were blurred, and then the CDR was not made out, and then there were few pigmentary changes which were noted at the macula. So and then since there was relative afferent pupillary defect which was associated with optic disc edema, we went ahead with optic nerve function test. First is the color vision, which was done by Ishihara chart. The right eye color vision was within normal limits, whereas the left eye red green and blue yellow defect was noted. So and then the contrast sensitivity, which was done by Pelli-Robson chart, and the right eye it was normal, which was 1.70, and the left eye it was 0.65, which was decreased. So and then the OCT macula showed significant foveal thinning in the left eye, whereas the pattern VEP of both eyes was within normal limits. So and then the MRI brain and orbits did not reveal any active optic neuritis or any infiltration of optic nerves. So and then we came to the working diagnosis of capacitabine-induced optic neuropathy with maculopathy. So and then we had sent a medical oncology review to change the chemotherapeutic agent. So actually it was changed. So and then at around actually 1 month follow-up, the visual acuity in the left eye was 6/6 parts. So and then the pupils were reactive to light, and then the fundus was showing resolving disc edema. So and then coming to the discussion, in the present era, the newer advances in chemotherapy has been a boon to the cancer patients, but there is a concomitant rise in the unheard adverse effects as well. So actually some of the well-known adverse effects are in the leukemic patients, which will be infiltrative optic neuropathy and also the retinopathy of blood disc areas. So actually there are very few reports of optic neuropathy associated with cytarabine and daunorubicin, and then the maculopathy which is associated with hydroxychloroquine and desferoxamine. So actually there is very rare reports of optic neuropathy and also maculopathy coexisting in the same patient on chemotherapy. So and then my conclusion will be the optic nerve toxicity associated with the chemotherapeutic agents has been reported in rare instances. Here actually the ocular the complications in these patients are usually neglected. As a systemic condition will gain the priority. So the early detection, proper examination, workup, and timely stoppage of the causative drug will help in limiting the structural damage, functional disability, and will lead to a better quality of life. So actually, oncologist and the ophthalmologist can work in harmony to facilitate the early referral and preventing the irreversible ocular toxicity. Thank you.
You haven't shown the OCT. After that, the vision has recovered, the macula OCT. And have you done the RNFL also? Because your pattern VEP was normal, color vision was decreased, and contrast sensitivity was decreased. And you have shown the OCT,
Yes,
because the fundus picture is almost the same that you have shown that before stopping the drug and after stopping the drug. So I think OCT picture would have been, because so much thinning at the macula and vision regaining to 20/20, and it was not that much decreased 20/30.
Did you give IV steroids?
No, ma'am, we didn't give IV steroids.
Fine. You just
Slightly, we
withdrew.
just actually changed this actually chemotherapeutic agent. So and then we didn't give any steroids.
Review of literature with this drug. Any reports with vision loss?
Likely no, ma'am. Actually, with this drug, actually as such, there is no literature. So like with actually some other drugs like donoribicin
But
and
why
actually
the
citarabine.
macular toxicity? Any idea?
Ma'am?
The macular toxicity, because you have shown affection of the optic nerve as well as the macula.
Yes, ma'am.
That's why, as sir said, the
OCT.
repeat OCT would have given you a clue. Thank you, doctor,
Thank you.
for an interesting case.